So now we are coming to the topic of electrolyte disturbance in ICU, which is very commonly seen during the ICU practice. So body fluids. The average body water is about 60% of TBW, 65% males and 55% females. What about sodium? Sodium is the major ion in the extracellular fluid. Normal value in blood is about 135 to 145 millimole per liter. Sodium is possible for maintaining the plasma and ECF osmolality, maintaining IV and ECF volume, has physiological role in generation of membrane action potential. Sodium concentration is regulated by renal system and endocrine system. Renal excretion of sodium is adjusted to equal the amount of ingested. Urine sodium output 1 to 400 milliequivalent per day. The normal is 90 milliequivalent per day. So, in the kidney, 96 to 99% of the filtered sodium is reabsorbed, 67% in PCT by active process, 25% in thick ascending loop of aldehyde, passively direct sector upon, 5% in DCT and 3% CD in exchange with potassium and controlled by aldosterone. Hyponatremia. What about hyponatremia? Hyponatremia means serum sodium less than 130 milliequivalent per liter. Less than 130 is mild and less than 145 is moderate. Okay. No linear correlation between degree of hyponatremia and symptoms. Symptoms depend upon the rapidity of the occurrence of hyponatremia. Okay. So there is no linear correlation and symptom depend on the rapidity of occurrence of hyponatremia. So because of difference between the regulation of total body volume and sodium concentration, it is possible to have hypo or hyponatremia in face of hyper or evolemia. So in case classification of hyponatremia, what we are saying that hyponatremia with a normal serum osmolality, hyponatremia with high serum osmolality, hyponatremia with the serum osmolality and with high serum osmolality. In case hyponatremia with the normal serum osmolality, serum osmolality is 280 to 295 milliosmol per kg water, called pseudo hyponatremia, and the causes are hyperlipidemia and hyperproteinemia like multiple myeloma. Hyperlipidemia every 4 to 6 grams per liter, increase in lipids leading to 1 milligram per liter decrease in sodium. Okay, so now hyponatremia with high serum osmolality. Serum osmolality more than 295 milliosmol per kg water, called hypertonic hyponatremia, caused by increased permanent impairment solids replacing sodium in the blood. What are the causes? Causes like non-sodium solutes such that glucose, mannitol and some other toxins like ethanol and urea, renal failure due to impaired water absorption. So management of hyponatremia with normal and high serum osmolality. Restoration of volume and free water deficit, treatment of non-sodium salts, such as toxins, treatment of hyperglycemia or mannitol level, treatment of hyperlipidemia or hyperproteinemia. Hypoproteinemia with osmolality, hyposmolality. Serum osmolality is less than 280 milliosmol per kg water. It is the most common type, and it means that the free water intake more than water loss. Those are the types of hyponatremia with hypoosmolality. Based on the clinical assessment of total body water and sodium content, it is classified into hypovolemic hypoosmolar hyponatremia, hypovolemic hypoosmolar hyponatremia, hypovolemic hyperosmolar hyponatremia, the causes are renal causes, diabetic causes, inactive use, renal tubular dysfunction, hyperaldosteronism. Non-renal causes are like GI loss, skin loss, dietary sodium restriction, and third spacing. These are the non-renal causes. Means there is a loss, GI loss or skin loss. So now manifestations of hypovolemic, hypoosmolar, hyponatremia, intramuscular volume depression, hypotension, orthostatic hypotension, tachycardia, and skin dehydration. Management of hypovolemic, hypoosmolar hyponatremia: replace the volume depression to depress ADH by acetonic, crystalloid, or chloride and blood if not enough. So now management of hypovolemic, hypoosmolar hyponatremia: replace the volume depression to depress ADH by acetonic, crystalloid, or chlorides and blood if not enough. Replace free water with sodium by water restriction and furosemide. Replace the urine output by acetonic saline. Hypervolemic hypoosmolar hyponatremia. It is called dilutional hyponatremia. Causes are like CHF and liver cirrhosis and metabolic syndrome. Nephrotic syndrome. In case manifestations of hypervolemic hypoosmolar hyponatremia, total body water increased and the patient is edematous, but the effective circulatory volume is low. Means in which urine sodium is less than 15 milliequivalent per liter, urine osmolarity is more than 400 milliosmolar per kg water weight. Management of hypovolemic hypoosmolar hyponatremia. The aim of management is to improve the effective circulating volume, renal function, cardiac function, and distal tubular delivery of sodium. Evolemic hyperosmolar hyponatremia, syndrome of inappropriate ADH secretion, excess ADH secretion, secretion stimulated by non-osmotic, non-volemic factors such that emotional stress, endocrine disorders, excess hypertonic fluids, and CNS disease. Management of syndrome of inappropriate ADH secretion, treatment of the cause is that a brain tumor resection, free water restriction, furosemide to get negative water balance, replace fluid by acetonic or hypertonic saline. Water intoxication such that psychosis, heavy beer drinking, absorption of hypoosmolar fluids during prostate resection. Urine osmolarity is less than 100 milliosmolar per kg. Right. General manifestations of hyponatremia. Serum osmolarity and cellular dehydration are the main insultant. CNS cells are the most affected by changes in osmolarity. CNS compensate for slow changes in osmolarity affected severely in acute conditions. General manifestations of hyponatremia. In acute hyponatremia, CNS manifestations begin by lethargy and confusion up to seizures, cerebral edema and coma, and GI symptoms. Management of hyponatremia. Management is based upon the treatment of the cause, restoration of serum sodium concentration, and normalization of serum osmolarity. This treatment of the cause is a very important factor in this case to manage the hyponatremia. Correction of serum sodium, acute changes in serum sodium. So management of hyponatremia treat the cause, restoration of sodium concentration, and normalization of serum osmolarity. Correction of serum sodium means acute changes in serum in sodium concentration should be treated rapidly, but chronic changes should be treated more slowly. In acute hyponatremia, means less than 2 days, corrected by the no faster than 1 to 2 milligrams per liter per hour. Serum sodium not increased more than 130 milliequivalent per liter. and avoid hypernatremia. In presence of seizures or increased ICP, intracranial pressure, the correction could be in 3 is to 4 millimole per liter in the first hour or even 8 millimole per liter. In chronic hyponatremia, correct by less than 12 millimole per liter per day, the rapid correction may lead to osmotic demyelination syndrome, severe neurological deterioration after 1 to several days of rapid correction. The amount of sodium required to increase serum sodium concentration is calculated as the equation. Sodium required is equal to desired sodium as present sodium as TV water. TV water is BW 0.6 in male and 0.5 in females. The desired sodium should not exceed 130 milliequivalent per liter. Hypertonic saline used only in severe hyponatremia. Hypertonic saline should be stopped when patient becomes symptomatic. Plasma sodium increased by 20 millimole per liter. Plasma sodium raised to 120 to 125 millimole per liter. Hypernatremia. So hypernatremia means if the serum sodium is more than 150 milliequivalent per liter, it results from loss of free water or gain of sodium ions in excess of water. So these patients are the extreme of age for inability to drink, a very sick patient, comatose patient, severe hypernatremia producing cellular dehydration, hyperosmolality in most cases. Classification of hypernatremia: hypernatremia with hypovolemia, hypernatremia with hypervolemia, hypernatremia with evolemia. So, in case hypernatremia with hypovolemia, causes are like renal water loss, osmolalitics in excess, tubular renal disease, and adrenal failure. Non-renal causes of water loss is that GI loss is the diarrhea, skin loss, severe sweating, peritoneal dialysis, urinary sodium is less than 15 millimole per liter, eosmolar is more than 400 milliosmolar per kg water. Hypernatremia with hypervolemia. Causes are iatrogenic, sodium-containing compounds, mineralocorticoid in excess such that aldosteronism. Cushing disease. Hypernatremia with evolemia. Causes are hypernatremia with evolemia. Causes are evolemia. Causes one little water loss, DI like DI, renal disease, and diuretics, urinary sodium variable. Second is non-renal water loss, such that diarrhea, fever, in urinary sodium available eosmolarity more than 400 milliosmol per kg water. Diabetes insipidus, central diabetes insipidus, idiopathic diabetes insipidus, following head trauma, and neurological disease. Nephrogenic diabetes insipidus, and which sickle cell nephropathy, chronic pyelonephritis, and multiple myeloma. Clinical features of hypernatremia are neurological features such that begin by irritability to focal deficit up to cerebral dehydration and hemorrhage. Cardiovascular features, manifestations of volume depletion up to shock. Management of hypernatremia: acute hypernatremia treated rapidly, while chronic state should be treated slowly to avoid neurological insults as the seizures and cerebral edema. Management of hypernatremia: treatment of the underlying cause, volume depletion with isotonic saline, hypertonic fluid used after volume depletion, water deficit replaced or 24 to 48 hours. Sodium overload removed by loop diuretics and renal dialysis. Treatment of diabetes insipidus, hormone replacement, desmopressin. In nephrogenic diabetes insipidus, desmopressin is not completely beneficial, but limitation of salt and water intake, and thiazide diuretics are the treatment. Now, in case potassium, we come upon the potassium, serum potassium is, and the range is 3.5 to 5 millimole per liter, but 98% of the total body potassium is intracellular. Then a decrement of 1 millimole of serum potassium concentration means a loss of about 200 to 300 millimole per liter in body potassium. Functions of potassium in the body. The main function is the stability of the action potential of the cell membrane. Then the main effect of serum hypokalemia is hyperpolarization of resting membrane potassium, affecting mainly the heart, producing arrhythmias. Now, the function of potassium means stability of the action potential and the heart producing arrhythmias, and the main effect of serum hypokalemia is hyperpolarization. Potassium also play a role in a cofactor in enzymatic reactions, and it maintains the normal cell volume. It affects the IC hydrogen ion concentration and participate in regulation of intracellular pH. So hypokalemia means serum level less than 3.5 millimole per liter. Because potassium is primarily an intracellular ion, hypokalemia may occur in low, normal or high total body potassium. Causes of hypokalemia. Redistribution such that shift of potassium from extracellular fluid to intracellular fluid, and hypokalemia is serum level of less than 3.5 millimole per liter. Because potassium is primarily an intracellular ion, hypokalemia may occur in low, normal or high total body potassium. Causes of hypokalemia. Redistribution such that shift of potassium from ICF to ICF, insulin, metabolic alkalosis, catecholamines, so that cholesterol, and periodic paralysis. Non-loss of potassium such that gastrointestinal loss, mainly diarrhea and repeated suction, discontinued diuretics with alkalosis, and skin loss. Third is renal loss of potassium. The most common causes of that diuretics, it lead to increased renal tubular flow, aldosterone secretion and alkalosis, aldosterone causing potassium wasting in presence of water. Renal tubular damage from nephrotoxic drugs, diabetic ketoacidosis as a result of osmotic diuresis, and increased excretion of non-resorptive ketoacid anions. Clinical effect of hypokalemia. Cardiovascular arrhythmias, that conduction defects, vascular renal tubular damage from nephrotoxic drugs, diabetic ketoacidosis as a result of osmotic diuresis, and increased excretion of non-reabsorbable ketoacid anions. Clinical effects of hypokalemia are cardiovascular, such that arrhythmias, that conduction defects, vascular postural hypertension, muscular weakness of the cramps, and neurological. Renal features like reduced glomerular filtration to renal damage, gastrointestinal paralytic ileus, and paralytic gastrointestinal ileus, nausea and vomiting, and metabolic features. Management of hypokalemia. General measures: treatment of underlying disease, correction of other electrolyte disturbance, discontinue offending drug, and correction of acid-base imbalance. Potassium replacement. Precautions: the maximum infusion in 10 is to 40 millimole per hour. The minimal concentration given in peripheral big vessels is 60 millimole per liter fluid. Potassium should be diluted in non-glucose solutions. Potassium replacement. In severe cases, serum potassium is less than 2 millimole per liter, or these changes from muscle weakness. Give up to 40 millimole per hour in 1 liter normal saline IV. In mild to moderate cases, such that serum potassium is more than 2 millimole per liter and no ACE changes. Hyperkalemia. Hyperkalemia means serum potassium is more than 5 millimole per liter. It may occur with low, normal, elevated total body potassium stores. Pseudohyperkalemia results in potassium is released from cells in the test tube. Most common causes of hyperkalemia are decreased excretory capacity, excess intake of potassium. Means excretory capacity and excess intake of potassium. That is translocation from ICF to ECF. Means if it is mother from unit per liter. Most common causes of hyperkalemia are decreased excretory capacity, excess intake of potassium, and translocation from ICF to ECF. Right. Decreased excretory capacity, renal failure when GFR decreased below 10 millimole per minute, potassium sparing diuretics, hyperaldosteronism, AC inhibitors, and NSAID. Excess intake of potassium means atherogenic excess potassium supplement, stored blood, salt substitutes. Translocation from ICF to ECF, in which what we are saying that translocation from ICF to ECF, acidosis, severe catabolism and rhabdomyolysis, insulin deficiency, aldosterone antagonists, digest toxicity, mass probability. Cause clinical features of hyperkalemia. Clinical features of hyperkalemia are cardiovascular arrhythmias, mainly ventricular tachycardia and ventricular fibrillation, heart block, delayed conduction, undelayed conduction. Clinical features of hyperkalemia are neuromuscular manifestations like paresthesia, muscle weakness, flaccid paralysis. What is the treatment of hyperkalemia? General measures, treatment of the underlying cause, restriction of exogenous potassium, and removal of offending drugs. It is very important to treat the underlying cause because without the treatment, it is life-threatening to the patient. So, removal of the offending drugs and underlying cause treatment is very much important in hyperkalemia. Like previously, in that there are cardiac changes which lead to arrhythmias and which is a fatal thing. So, treatment of hyperkalemia, if there is mild hyperkalemia, then restriction of potassium and liberation of sodium and water are enough. Okay, but when a treatment of in severe hyperkalemia, when the calcium, first is calcium, 5 millimole per IV over 5 minutes, sodium bicarbonate 50 to 100 is to 100 millimole over 5 minutes, and use of loop diuretics. What is the treatment of hyperkalemia again? In resistant cases, potassium binding resins in 50 millimole, 50 ml, sorbitol is 20 to 30 gram orally, 4 hourly, inhaled or infused beta 2 blocker and B2 blocker and dialysis is the main line of treatment in patients of hyperkalemia. So before coming to the end, I want to say you that we are seeing many cases of electrolyte imbalance in our clinical setup. और आप लोगों ने को ज़रूर एक्चुअल में क्लिनिकल सिम्टम्स और इसके आधार पे आप अगर इजीली एंड क्विक अगर आप वॉच रखेंगे तो यू विल गेट डेफिनेटली रिजल्ट्स. सो this is the end of the topic of hyperkalemia. Now we are going to some other topic like fluid correction and electrolyte imbalance and pancreatitis. The two are covered, and the next is after the next lecture. Thank you.